So we can knock those out because they're pretty simple, and then the rest we'll do when we get to the SI joint and pelvis. Right? So with this, the posterior shear test is a test for instability. I think it's one of the more difficult ones to feel because it's like a mobility assessment, right? Whereas the other two is a little more clear that you have an issue. But it's still a very valid test to be able to do. All right, so I need somebody standing up here. All right, shut off, please. All right, things not to do in the clinic. You laugh, but the things that you consistently do in the classroom are going to translate to the clinic.
Oh, jeez.
Right? Because it's just subconsciously you're going to do it, and then you're going to have to deal with the aftermath.
So whistle at one
Do not whistle at patients.
Big bold. Because then you're going to get that email.
Yeah.
Dr. Jenkins, and who's Dr. Jenkins going to reach out to?
Oh boy.
You.
He taught
And
that.
he'll be like, listen, he
did it.
He did it to me. It happened.
Oh,
All right, so hands over the belly button. All right, so you have the patient's hands over the belly button. Then with your finger, you're going to palpate the inner spinous space between L5 and S1. Okay, so very similar to what we did in sideline, right, for flexion extension. So I'm going to palpate that area between L5 and S1. And then I'm going to just apply a gentle pressure through the hands. Okay? And what I'm feeling for, right, so now I'm at L4, L5, pushing, 3, L4. So I'm pushing.
Okay, each time you put pressure on this side, you're also putting pressure
so
through the
I'm
belly
putting
button.
pressure, right? And what I'm looking for is, does something move more than the other? This level is hypermobile, right? And then I move up. Right, so here I feel nothing, here nothing, here that bad boy moves. There that moves. Right now, how did I know that? Right, just looking at it. Right, look for that where that hinge point is. That hinge point is typically going to be where things are hypermobile, hyper with an E. Right, so and typically in the lumbar spine that's going to be L2, 3, 4. Right, in the cervical spine 4, 5, 6. Right, but you look for where that hinge point is, and that's when I would expect. But this, nothing. Nothing. Then I get there, right? And then you can see it, right? So it's a nice way to pick up again, right, where things fall, right? Now, you can flex. You
Does
can
it have to
flex
be
your back.
one finger, or can you do like, or doesn't matter?
However you feel best. Middle finger, index finger, one finger over the other.
You said interspinous space.
Interspinous space, right? Yes.
And they put their hands over the belly button
Yes.
and your hands over their hands.
Yep.
And just working with it.
Work way up, right? Now, as you just saw on him, right, L5S1, 4, 5 was hypo, right? 3, 4, hyper, right? So here's the reality of things, right? As we get into next week, right, we've already talked about low back pain with mobility deficit. We're going to talk about low back pain with movement coordination. Typically, they both exist at the same time, right? And we need to wrap our heads around that. In a testing environment, there's going to be one clear-cut diagnosis. Or at least we think it's a clear-cut diagnosis. In the real world, most people are going to have them both. Because typically what happens is, right, somebody can come in, they're loosey-goosey. Okay, that you need to stabilize. But most of the time, the people who are loosey-goosey then get stuck. And so they present with a mobility deficit, but when you clean up that mobility deficit, they really have movement coordination issues, and you still need to address that. That's the most common thing that you see. So like in his case, right, we may need to manipulate L5S1, but then we got to stabilize L3, L4. That's the most common thing you're going to see. Right? Because when we talk about our two categories, people moving too much and not moving enough, right? Our bodies naturally adapt to it. Right? And so as a result, most people have both. Okay? And that's one of the reasons why the treatment-based classification system, right, when you really look at the numbers, it's nice, again, as a novice to use, but when you look at it, they'll say that 70% of the patients can fall into more than one category. Right? So here is my true clinical pearl. Right? If you go in, you take an expert history, and you look for and find all of the impairments, you'll be fine. The diagnosis doesn't. The diagnosis is a label so we can get paid, it's a label so that we can communicate with one another. But if you find all the impairments are gonna be something's moving too much or it's not moving enough. And if you address each one of the impairments, the patient will get better. Every time. Right? No diagnosis. Now you got a diagnosis for the patient and to explain all of that stuff, but that's why, I want to kind of give you that. If you look for everything, you're more likely to find everything, and if you find everything and you address it with just one thing, your patient will get better. Hypomobility, hypermobility, right? I would then go in and say, okay, rectus abdominis, okay, transverse abdominis, 2+. Right? Glute med, 2+. Right? Glute max, 2+. Right? Hamstrings, probably 4+. Right? So based off of all of that, right, and that's just doing postural assessment, right, and that little mobility assessment, right, manipulate L5S1. One exercise to activate the transverse abdominis, one exercise to activate the glute max, one exercise to activate the glute med. I'm done. 4 things. And that patient will get better because those are the impairments. And you need to be able to communicate that to your patient because it seems way oversimplified. And I was like, that's it? And I said, listen, I just gave you 2 things, but the 2 things, right, patient with stenosis. One of them is to open up that foramen, right, so the nerve doesn't get pinched. And then I gave you a little nerve tensioner, right, to pull that nerve through that new open area. Those are your 2 big impairments. That's all you need. You get buy-in with that. And the patient's more likely to do their stuff, right? Because you've all seen it, the patients walk in with their 10 pages, right, of exercises. How many you need? And as we get into treatment, we're going to talk about overdosing because most PTs overdose, big time, right? And so we're going to need to get our minds, for those of us who have, past in personal training and, picking heavy things up and putting them down, right? That's good for us, but with people who are in pain, don't need to be doing that, right? Need to keep it simple. Right. So that is the posterior shear test. Then we have the prone instability test and the leg extension test. So, prone. So we'll do the extension test first, right? And so this one's nice and simple, right? We know that, okay, we don't know yet. We will know when you review next week's materials that people with movement coordination do not like extension. Very similar to patients with stenosis. Why? Because one vertebrae slides forward, right, and goes into extension, compresses, closes that lateral foramen, and makes it unhappy, right? So we'll talk through that more next week, so don't worry there. So all we're gonna do is take both legs and we're gonna lift them about 18 inches off the table, right? Because as we do, that's gonna extend the pelvis and drive that lumbar spine into lordosis, extending it, and look for reproduction and symptoms, right? The downside is this, you gotta pick up the patient's legs, right? But what I recommend, smarter, not harder, we start here.
Oh, it starts lowering them. Wow, you're so smart. Oh, my knee. Wow.
That's why they pay you to do books.
That's why you
Not
did it.
us.
That's why you did it.
That's what we paid.
That's
I
why.
would have been like, this is why I'm blocking you.
Honestly, I wouldn't mind if I was gonna start down here in the
Right, and so that's why I always say when you walk in, right, assert dominance, take the high-low table. That's what I do every morning, right, in the clinic, right, and then somebody, right, Dr. Cooper has to come and, right, say, okay, I have a patient that I really need this for, can I have it, right, because this is our working space, this is our material, right, for a football player, it's a football, right, for us, the treatment table. So yes, I can stand here and I can lift his legs 18 inches, or I can put him in a position where I can just lift the table and do the work. All right? So utilize the tools that you have. It will save you and your back. All right? So looking for a reproduction of symptoms. That's it. Just little work. All right? So, any questions on that? Go ahead and stand up.
How many degrees did you say it was?
About 18 inches.
Oh, inches on.
All right, we're gonna come down. All right, the prone instability test. All right. So this one is a great test. It's actually more specific and sensitive to be able to do, but it's just a tougher position to be in, right? So you gotta make a good clinical decision to look at the patient and say, can they do this? Right? Because it is more physically taxing. Okay. So I'm gonna talk through the test first, then we're gonna do it, all right? So the patient is going to lay over the table and grab on. Okay, then what I'm gonna do is I'm gonna start at L5 and I'm gonna do a PTA. I'm looking for the painful segment. Because typically when we do a PTA, the painful segment is the hypermobile. Okay? From there, we got two options. Okay? The first option is you have the patient extend their legs. So now you gotta think about, okay, what patient can do that? They're gonna hold onto the table and lift their legs off to the floor, which is why this might not be a good test for somebody, right? That brings them into extension, right, and should reproduce their symptoms, right? Then I can have them lower their legs. I can press down on that level, which is gonna do what? Create stability, right? And then as they lift up, the symptoms should be relieved.
Because you said when they flex their legs and then you put it back.
Yes.
Then it's stable.
Yes, because as they go into extension, it stays where it should.
Out, back in.
Yes.
And you said the painful segment is normally the hypermobile
Hyper,
segment?
yes. Right? So that's one way to do it. So let's walk through that and then I'll show you the second way. So grab onto the table. So typically you want the table at ASIS height, right? They're gonna stay there, right? And I'm gonna say, okay, which one's painful? Which one's painful? Which one's painful? Right there. How about that one? Nope. Okay, so now we got this. Okay, so now I'm gonna say, go ahead, lift your legs up. Right? Does that reproduce your symptoms? Yes. Go back down. Okay. Now I'm gonna apply a PTA pressure to create that stability so it doesn't move when he extends, and go ahead and extend. Is that better? Yes. Positive test. Okay. That's a lot of work, right? Especially for the patient. So for the patients that I'm gonna use this, which is typically gonna be my healthy population that I know can get into this position, right? I'm still gonna go through and say, which one is uncomfortable, which one's uncomfortable, that one right there, great, okay? My hand is gonna stay there, I'm not applying pressure. Okay, go ahead and lift up. Does that reproduce your symptoms? Yes. Now I apply pressure, is that better? Yes, positive test. And if they say no, something else. Right. So, prone, posterior shear test. Right, working our way up. Right, lumbar extension test, 18 inches. Prone instability test, patient down. Right, do a little mobility assessment, find the uncomfortable one, have the patient lift their legs. Right, then either press down to see if there's relief, or have them put it down, press down, and have them their legs. Two ways to do it. Right. Great. Those three. Let's do it.
Ready?
We need to work on these